Without further ado, I haven't said that for ages, so I just had to throw that in. Without further ado, I'm going to now hand over to Stacey and friends, and we can learn about more projects which are part of the System Dynamics training program, which you've been delivering over the last 6 months. Stacey, over to you.
Great, thanks, Rachel. Yeah, we're going to be passing the baton back and forth a little bit because there's quite a few of us to talk to you today. For those of you that weren't at the last Huddle, we thought we'd give a general introduction again because we're aware that it was Easter and so some people may not have been at the Huddle last time. So Douglas is going to start by giving you a very brief introduction to System Dynamics to give you an idea of what it is we've been working on for the past 6 months. Yeah, Douglas, Sally and I have been running the Systems Dynamics Applied Learning Programme. And so today you're going to be hearing from us about a little bit about System Dynamics, a little bit about what was involved in the programme. And the main part of today, I guess, is for some of our participants to be showing you the projects they've been working on. I would ask that you understand that these are the participants' first attempts at doing System Dynamics modelling, and they've been on quite a journey to get to the point that they're at, and we're very proud of the work that they've been doing, but understand that it's still developing. So without further ado, I think I'm going to pass on to Douglas, who's going to give us a brief overview of what System Dynamics is.
Right, hello. Let me just move some things around my screen. Can everybody see my screen? Yeah, yes. Good. Okay. So just very quickly, a couple of shots that I showed last time, but with no comment. Other than that, there are links that you can follow that we will put in the chat if I can find the chat. And then just a final few thoughts about modeling and analysis and how they connect and how they differ, perhaps. So last time I mentioned these publications, the one on the left which is free and the one on the right which isn't free, but there's a lot more in it. So and also I showed you a link to a model, an actual, so you can go to the internet and play with this model. It's got quite a lot of explanation. Maybe you could put your hand up if you were here last time and actually went and had a look at the model, but and somebody could reassure me that at least one person did. So again, we'll put the link to that, make that available to you. But just a quick reflection on what the difference might be between being an analyst and being a modeler. And I would contrast analysis with, if you like, synthesis. So on this course, most of the people who came in the course were data analysts, and I guess that most of the people in this meeting are in that category. But it's obviously a diverse group, so you don't all do the same thing. But we might say that with data analysis, you start with data, and with modeling, you start with structure, with a sense of how things connect, and that your data comes from what has already happened. Generally, that's not to say you don't do some forecasting, but the data that you have is a description of the world as it has been. Whereas our modeling structures tell us what data we might need, and that might be data that we don't have yet. And so with analysis, to some extent, the truth is in there. You're trying to find out what's in the data and explain that to people. With modeling, perhaps the truth is out there somewhere, and we're trying to assemble something. For an analyst, managers are asking you questions. Can you tell me how many of these there were? How does this compare with last year? All kinds of things, I imagine. When you're modeling, then the analyst now has to learn to be the person who asks the questions. So it's not that the manager asks you the questions, it's more that you will ask them to explain how things work and what they know about it. And finally, the manager delegates. The manager says, well, go on this course, and come back and tell me the answer. And you may get a hint of that from some of the contributions this morning. Whereas with modelling, the managers must engage in the process. And the modeler, having gone on the course, will return with greater curiosity. So there's much more I could say about this, but I don't wish to imply a very simplistic view of what analysts do. But I think therein lies the difference. And with that, I'm going to hand back to Stacey, who will tell you a little bit more about what we've been up to since last September. Okay.
Thanks, Douglas. Yeah, if you go to that link, there is a model there that you can play with. It will show you examples of how system dynamics allows you to change variables and look at the differences in the stocks and the flows within that model. But let me try and share my screen. 1 second. So we've been running the course as an applied learning program, we'd like to call it, since September, and we had our last session in March. The course itself, we managed to bring together funding from a couple of places, from the Midlands Decision Support Network, from the Midlands and Lancashire CSU, as well as from NHSE. And that was to focus on system dynamics and building up the capacity of system dynamics in the ICS context. It was aimed at the analysts in health and care, not just in the NHS, but also in local authorities, those working in social care and public health, for example. And so through the course, we were aiming for them to gain a greater understanding of how system dynamics could be used. To get on that course, they were recruited via, well, you might have been at one of the huddles we did back in July, introducing what system dynamics was and giving a plug for the course at that point. But people were recruited via their intelligence function leads in the different systems and organisations. And part of that process meant that they had to have a project in mind already that was prioritised by their organisation, and to also have a project champion in place who was meant to help guide them and advise them on the project and link them to the people they needed to talk to. The programme itself had some further goals around trying to establish more of a community of people who could be peers and support each other. And so we were looking for a significant commitment to people, because system dynamics you don't just learn overnight. So it was 6 months, it was half a day a week, face to face, on Teams. It was all 100% delivered online, but the participants also needed time to work on their projects outside of those sessions as well. Yeah, out the way. Okay. So the programme was run by myself and with support from Sally Thompson, but we also had our expert in system dynamics, Douglas, who literally wrote the book. And we went through a journey. We started by focusing on learning about what system dynamics was, using a piece of software called Stella to help us construct the system dynamics models, building up in complexity as we went along. Used a variety of techniques. We had case studies that we built. We did some build along sessions. Along the way, we also had some workshops and some talks from guest speakers covering some of the wider things that you need to consider when doing modelling, such as problem structuring, facilitating groups. And we also had a panel session where we brought in people who have experience of doing system dynamics in different capacities. So we had Douglas giving more of his practitioner perspective. We had Hugo Herrera from one of the NHS trusts talking about the system dynamics situation within his trust. We had Antuela Takeo, who's academic from Loughborough University, as well as Vanessa Perez, who you'll hear from a little bit later today from NHS England. And as the programme progressed, the focus changed from those learning sessions to more support with individual projects and trying to support participants create their first system dynamics model. All of the videos from the sessions and the work we were doing was supported by a future NHS workspace that those participants have got access to and continue to have access to. You can see in the little graphic there, that was just running through some of the sessions that we went through to show our journey. And so we had 14 participants, 12 of which were recruited to participate in the course, and 2 others were observers who are involved in the course, but their licenses weren't bought by the funding. So the projects include a whole range of topics. Some of them changed along the way as well. And last time you heard from Tom and Sam, who were talking about the community mental health bed capacity model that they built, and also from Tracy and Jane, who were talking about the supply of care homes and how many care home places they might need in the future through their modelling. Today we're going to hear from Phil Alexander, who worked on a project along with Steve Dunne, who couldn't be here today, but they were looking at colorectal 2-week cancer weights. And also from James Turner, who's going to be talking to us about dermatology and particularly outpatients appointments for dermatology. And there are various other projects that people worked on along the way, some of which are still in progress, for example, and are developing. So reflections and feedback on the course. We had some really nice feedback from the participants. 12 of them got to the end. We've got the 8 projects that they were working on. They've had some good support from their organisations in terms of attending the training, but support, I guess, was a bit more mixed around project engagement and championship in the particularly in a developing ICS context where there's organisational changes and changes in structure and who your boss is and things like that going on. There were capacity issues, so even though we'd asked for people to have time to work on the projects outside of the course, that didn't necessarily happen. Where participants had to miss sessions, they did use the workspace quite a lot to look at the videos and found them helpful to catch up. It did take a team of us to deliver it online. So Douglas did the majority of the teaching, Sally and I supporting, but we had to do some flex around some of the planning around the sessions, particularly when the Queen decided to die. So we had to rearrange a session or 2 around that. And then we've had some really good feedback and some recommendations for the future. So it's all we're finishing up with the Midlands Analyst Huddle, sorry, I can't say the word today, where you've got some examples of the projects we've been working on. The workspace and forum is still up there for our participants to carry on using. We're going to be having monthly catch-ups with everyone just to see how they're getting on and try and support them further into actually using and applying system dynamics, and just so they can keep in the loop about what's going on with us as well. We'll be looking at some of the projects to see whether they're of regional value and perhaps we can expand them. And also we're thinking about how a community of practice might develop, and I'm not going to say more on that at the moment because we'll hear from Vanessa later. I am going to stop sharing my screen now, and I'm going to hand over to Phil, who's going to be telling us about their model. And stop sharing button. There we go.
Thanks very much. Firstly, hello everyone. I haven't attended this before, so a little bit about me. I work at University Hospitals of North Midlands. We're an acute hospital trust, and myself and Steve both work in the Information Services Department. I'm an analyst and Steve is a divisional business advisor. Steve isn't here today, he's on leave, but we both work together on this project. Which is about the colorectal cancer 2-week pathway. So there's a 62-day target for referral to treatment, and myself and Steve are both from a sort of analytical background, which I guess is the same for pretty much everyone here. And so the system dynamics approach, as was kind of alluded to in what Douglas was saying and what Stacey was saying as well, is sort of completely new to us and kind of not the opposite, but definitely a different way of working. Getting used to sort of asking questions of people rather than starting with the data was definitely a sort of new thing to us. So back to the project. We sort of chose the project because we thought it was suitable for the sort of modelling that we'd seen was possible in the Stellar software. We didn't want to choose something too complicated. Obviously, it's our sort of first time doing this, and both of us kind of deal with the emergency department quite a lot. So I think that was our sort of initial thought, that we'd probably do something to do with that. But the more we sort of thought about it, the more complicated it seemed that would be, because there's so many sort of pathways in and out of there. You could imagine the model kind of getting out of control. So instead, we eventually settled on the colorectal pathway, colorectal cancer. So eventually met with a colorectal consultant and the director and manager. It actually took place in the department, in the theatres. The consultant was sort of in and out of the theatre while we were meeting with him. He'd got like his scrubs on. Pretty it's kind of a different experience, because obviously, like the last few years, a lot of meetings and stuff have just been on Teams. So it was good to actually get out into the department, meet with a clinician, and hear about sort of the actual process itself. So he was able to provide us with a flow chart of the actual process, how it ideal world should work, and I kind of used that to translate that flowchart into a model, obviously with bits and pieces added on. We then we started looking at data, and we knew there was kind of something missing, so we then met with our cancer data specialist, who uses data from the Somerset Cancer Registry, and from that we were able to sort of better determine the start and end of the pathway. So I'm just gonna share my screen, actually, because it's probably easier to start talking about the model now. Here we go.
We can see that, Phil.
Thank you. Yeah, I was just going to say, hopefully you can all see that. I always have a bit of a jitter when I start screen sharing. So yeah, like I said, consultant provided with a flowchart, which I kind of translated into the model that you can see now. This is the kind of second iteration. When I started, I kind of built the whole thing, but didn't put any values or equations in. So it was just like a map for us to sort of start working on. But then through talking to Douglas and also like Stacey and Sally, I found it was going to be easier to just start small and build outwards, if that makes sense. So just to kind of talk you through what this actually is doing and what it means. It sort of starts with the patients taking a FIT test, that is a fecal immunoglobulin test. So that's a stool sample that is analysed. It's the referrals come from the community, so it's kind of not a part of the process that's necessarily owned by us, by the trust, but we actually do the samples. The samples are analysed by our pathology department, so we're able to get some data about the number of samples per week, and the like turnaround time on the tests, and also the proportion that are either above the result of 10, which is enough to take them onto the pathway, or below the result of 10, in which case they get referred back to the community, which is what's going on here. With a result above 10, they then come into our outpatients, so they get referred to outpatients, go onto the waiting list, which is what this stock here is. And from there, they either go to imaging, depending on the FIT test result and also other symptoms. they can go for imaging tests, or if the result is high enough or they're past a certain threshold with symptoms, they go to colonoscopy, which might then result in either a cancer diagnosis or not, essentially, in which case they will go for other tests. We've got an endoscopy in here. Just to point out, before I go to the interface, it's still very much a kind of work in progress, and we're sort of not quite confident that it's basically not running in equilibrium. So we do think there is a bit more work to be done on the model, but nevertheless, I'll go to the interface. So when I kind of created this, I basically wanted to make it as compact as possible, which I think is why I've only ended up with one page. And the sort of outputs that I wanted were the number of patients that are kind of in each stock in system dynamic terms. So the number of patients waiting at various stages in the pathways, but also I thought it was important to give these kind of total numbers over here. So the total days that patients are waiting in each kind of different pathway, considering that is basically what the target is and what we would want to use the model for. So I'll just take this into a live run. So it's running on its kind of default values at the moment, but using the interface, you are able to tweak these values, and you can actually see how it affects the various charts. So, you know, what would happen if we were to improve our waiting times for outpatients, and you can see what the results are, both in the outpatient waiting and also further down the line in the colonoscopy waits and so on. Yeah, and it also changes the total times in the pathways over on the right, which I think is possibly the most important output. And the way this works is these are like the average times. This is just how the sort of modeling process works, rather than being kind of actual data as such. It's a what if scenario, and these are the average times. Yeah, so I think just my closing thoughts are just that the sort of course itself has been really good and really interesting, and it's just a complete change to what myself and Steve, who've done the data analysis and the modelling, are used to. Just it's just so different, and you can kind of see how you could apply this to all kinds of different pathways, certainly within our trust, and I'm sure in the community. Yeah, I just wanted to say that really, and thanks to the strategy unit and to Douglas for all their help on the course.
Well done, Phil. Thanks for presenting your model. Okay. It's a really nice model. I really like the way that your model structure itself, people can understand how people flow through that structure that you've got there. And you showed a live run there on the interface, but you've also got the buttons so that you could run a little bit of the model, change a number,
yes,
run a bit more. So it's got, although you've seen sort of a steady state, kind of it reaching steady state in those charts, there are ways of running for a bit, then increasing the number of samples per week or decreasing them, etc., and seeing what impact that has. It's a really nice interface as well. I think you've laid it out really well.
Thank you.
I think so it's easy to understand. Next up, we've got our final example for today, which is James from Wye Valley Trust, and he's going to be talking about his dermatology outpatients model.
Hi folks, thanks Stacey. Yeah, so without shouting, I'll calm down. So we already have in place a set of RTT models that we've had for several years in the organisation, but it's all Excel based, and it's, you know, we calculate waiting times, we monitor activity and this kind of thing, and we predict RTT performance based on it. So it's well established. what we wanted to do was use Stellar Dynamics and look at it in a different way, and it's really opened our eyes to what we can do with modelling rather than Excel, which is fantastic. It's been the bedrock of all of our work for years. Using System Dynamics and using Stellar Architect software has opened our eyes, and we're going to be doing so much more. If I can just take you briefly through our short journey. Hold on. Okay, right. Everybody see that okay?
We can see that, James, yes.
Marvellous. Okay, so what you're seeing on this front screen, we have on the left-hand side our Excel version of what we currently do around monitoring and predicting RTT for outpatient first appointments within dermatology. On the right-hand side, following the yellow arrow, is effectively kind of what I've built that we're going to go through and have a quick look at some of the outputs today. This slide is about the general sort of flow of elective pathways or patients within the organisation. At the start point, you have a referral, you come into the organisation, you typically go onto a first appointment waiting list if your referral is accepted. To get off your first appointment waiting list, you either get seen or you DNA or something similar. And once you get seen from a first appointment, you then have a series of decisions, don't you? Typically within the NHS, you'll go onto a follow-up waiting list or get sent off for diagnostic tests, or you go straight onto an elective list for surgery or an admission for treatment. And depending on where you are in that journey, as you can follow the green flow of arrows or convert green arrows, let's say, you move around the various waiting list stocks, which are highlighted in the boxes. And you can go around loops and whatnot, go around follow-ups and back to inpatients or elective lists and back to follow-ups. But you never end up coming back to a first appointment waiting list. Once that's done, it's always done. And that's where I've ended up focusing with Stellar Architect. So again, here's just a very quick view of what we currently do for dermatology. We do this for all specialties within the organisation, and that's the end result of our weekly operational delivery tool from the financial year 22-23. If you look at the bottom left chart, which is labelled up waiting list size, monitoring and predictions, the pale blue columns are a snapshot of the size of the waiting list week on week on week throughout 52 weeks for the year. At the start of the year, we've already done a lot of pre-work around what we think the waiting list is going to do, and that ended up being the blue line. And then each week we re-predict what we think our ending at waiting list size position is going to be throughout the year. So we've already got a certain amount of functionality within it. And Excel is great, but it's not dynamic in the way that Stellar Architect can be. It's so much slower to try and make decision changes based on the information you're seeing. So that's where we ended up with the design of this model. It's not as neat as the previous presentation, because I'm just a little bit scatty when I do these things. But effectively, on the left-hand side, we have referrals, which lead into our waiting list, which you saw on the previous diagram. And then your outputs, you become in attendance, DNA, you get discharged, you could get rebooked to all of these different options. I appreciate that's great, but it doesn't really give us anything to look at right now. Okay, so what I wanted to do with the organisation is understand how our referrals work compared to our capacity. So if we ran a model and we had so many referrals within a year, say 3,900, but we know based on this first appointment waiting list, we've only have capacity to see 2,600 patients. So we've already got a gap of referrals to capacity. What that does is create a mismatch, and what it effectively causes is our waiting list, our green line. Think of this as weekly snapshots. It grows throughout the year, throughout the year, throughout the year. So we started the year with 794 patients. We end up with 1,900 patients. So the waiting list grows by over 1,000 patients, which is fine because we always put on additional capacity through the form of waiting list initiatives or hiring in locums, or we appoint substantive staff into posts within the service. But it's always difficult for the organisation to really get a feel or a handle on how we can control it, or when we need to put capacity in to be able to deal with this. So this effectively is the final screen that I want you to look at. I might just take you through it. We have the top section, or the top third, let's say, is all about referrals, how many we get in, and helps us perform sort of what if scenarios. What happens if referrals increase in 2-week wait and upgrade referrals? What happens if referrals increase or decrease within urgent referrals or within routine referrals? So as part of a training tool, effectively, if we increased our 2-week wait referrals by 8%, or another 166 patients, it will increase our waiting list size at year end. So we get people to understand what happens. We'll put it on a sheet, I guess, really, so we'll give them numbers to work with. So going back through these other numbers, we know what our current capacity is, which was 2,600. So we've got a gap of nearly 1,300 patients, and our referrals grow. Waiting list grows from 800 to something like 1,900, grows by 1,100 patients. So what we can also do here is tweak our DNA rates. What happened if we reduce our DNA rate, typically from 6% down to, crikey, 3%? So our DNAs come down to 81. Our waiting list doesn't grow by quite as much. So we're just getting people to understand what happens if they can improve or reduce various things. So if DNAs go up to 9%, it's actually 243 DNAs throughout the year. But what we're really aiming for is how much more capacity do we need to do? So I've sort of tried to answer this in a couple of ways. Bearing in mind this gap of waiting list size of 1,100 at year end, how can we get to, how much capacity do we need to do to maintain the start position, so of 794? There's two ways of approaching this. We can either put in flat capacity, if you like. We can put in additional 10 new slots per week. And as you do this, you can see the chart on the right-hand side, the green line starting to flatten out. I'll move it up to 15, it comes down a bit. It comes down a bit. So I can effectively find a number really quickly, he said. It's at about 23, between 22 and 23 new appointments a week would need to be delivered. And that would effectively get our waiting list in control. So that would manage our capacity gap. Now that's great, but not everyone can guarantee that they're going to put on 22 slots per week every single week. So the other way of delivering our capacity is to use one of the functions within Stellar, which is you can effectively draw on, called sketchable. So I can draw on this red line appearing on the bottom left, is saying, what if we did this many new appointments per week, starting at 20, maybe increase it to 40 by week 13, and come back down again. And you can see that the chart on the right-hand side has dropped straight back down. We've actually put on 1,600 new appointments, and it's reduced the waiting list way down to 353. And again, not all organisations can recruit or guarantee capacity like that. But let's say we were going for the locum approach. So we're going to get a locum in for the first 9 weeks. What would that do? The waiting list goes, okay, it improves it. Okay, so let's put on some capacity later in the year. This will help us sort of deal with the finances. Can we get the same sort of answers? I'm just going to tweak it across to get us to the same. So we can deliver our capacity by putting on another 1,100 slots, by getting in locums for sort of 3 periods of 8 or 12 weeks. It means it's easier to plan, it's easier for the finance, and it gives us an answer for where we need to go next. The model itself is I've only got as far as the first appointment waiting list. I need to then do this, repeat this for the follow-up waiting list and for the inpatient waiting list, so we can get a whole service reviewed, and we can work out what we need to do, when and how it can get signed off. It can support business cases, it can do all sorts of things. And yeah, that's effectively where I've got to. So thanks for listening to me.
That's great, James. I do like your use of the sketchable graph to be able to adjust your plans and try out different staffing capacities at different times. Because you can't necessarily have just a flat average all week. It's really nicely laid out interface. And yes, your model, there's a lot going on, so it is going to look more complicated because you've got so many feeding and impacting on how many first appointments are needed. So yeah, you've done a good job of trying to map it all in there. We're going to hand over now to Vanessa Perez. She's from the Demand and Capacity team at NHS England. She's the technical lead for System Dynamics Modelling there. Hi, Vanessa. Thanks for joining us.
Hi, Stacey, and hi, everyone. Unlike James and Phil, I didn't attend the training. I'm just stepping in for my colleague Edwin, who is unwell today. But I do have a background in system dynamics modeling, and I work with Edwin in the national team trying to embed system dynamics and system level modeling, not only system dynamics in the wider NHS. So the Edwin's presentation, I didn't make any change. I'm gonna try to let the presentation talk by itself, and then the second part. So the first part is Edwin's reflections on the training, and then there is I'm gonna talk about our offer from the national team, and then why we still believe that there is a need for a system dynamics community of practice, even though there have been attempts of using SD. So as I said, first Edwin's reflections. I'm just going to pass through the slides, and I hope everyone is okay with that, because I think it's not fair on me to talk about that. I'm going to just let you a couple of minutes to read out Edwin's reflections. So I hope I have given you enough time, and please tell me if not, to read the slides. Was it enough? Did people see that properly? Okay, great.
So those, and we can share them later if that would be helpful.
So I think the feedback from Edwin is very positive, but there is also they are also highlighting at the end that the support needs to be ongoing in the future, and what can we do? And I think that's a really good connection to what we are going to talk about next. So in the national team, we do have a system level support offer. I have to say that our team is very small. Is 8 people in my team supporting nationwide demand and capacity planning. So you can imagine that we cannot do lots of like enhanced support. But we try to cover, we have like 2 areas. We cover operational demand and capacity planning, and since 2021, we started doing system level demand and capacity support as well. So we run webinars throughout the year. Even though we do lots of emphasis on system dynamics, we also mention and raise awareness about discrete event simulation and other approaches that could be used for modeling at system level. We have, and this is open to anyone, support surgeries as well. At the moment, we have 3 slots a week. You email our team, and we allocate one of these sessions to you. If you have, for example, you are starting a project and you are not sure what type of approach you should use. Should it be discrete event simulation, or should it be this system dynamics, or perhaps agent-based? We can support with that. We have, my background is system dynamics, so because we are not experts in all the possible approaches, we are partnering with other modeling experts, and we bring them into the session. So we have some understanding of Stella software, Benzene software for system dynamics, but also the other partners we are working with, they know some of the discrete event simulation software. So please feel free to reach out to us and book one of those support surgeries if you need support with any project. We have created a section in the Future NHS network about system level modeling in particular. We have something about system thinking, which we believe is the foundation and where we would like people to start from when we are embedding in this journey. We know that is a significant shift in the mindset we have in the NHS. So building on the foundation and system thinking is something that non-analysts should be doing. I would say should be doing, not that I think we need to be pushing people a bit and saying this is something you should be reading, even if you don't get into the technicalities and the modeling part of it. Understanding the principles of system thinking is important. You can follow Edwin for the offer. We are planning some webinars starting on in May. We are still arranging the dates, but we are gonna do a session of webinars, a series of webinars starting in May, and Edwin will be posting those dates on the Twitter account. So our relationship, I think, with the strategy unit has been really closely in the last couple of years, because you are trying in the Midlands to embed SD, and there is this other national team also trying to do similar things, rather than working in isolation. We are trying to bring the two projects together. And we have found that there are these two pockets, but there are even more pockets of use of system dynamics in the wider health and care sector. But we believe it's still very limited. Usually, in this case, you had Douglas. I know Douglas and his work, and it's amazing. But there are other consultancy firms supporting different system dynamics modeling projects, in particular in health and care. And it tells a lot that there is a need to increase the number of system dynamics practitioners within the NHS, because we are relying on consultancy firms to support us in these projects. I think it's a very long journey. We are not gonna to have like a critical mass of system dynamics practitioners in the NHS in the next year or so. We need to do lots of work for at least 5 to 10 years to be able to have like a critical mass of practitioners in health and care. So that's why the argument is very strong to improve the internal capability in health and care. And we have done some work about what are those domains, not only the technical ones that are required for system dynamics and other system level modeling projects to be successful. And I'm gonna mention those different domains later. There is in our Future NHS platform, there is a resource. It's a maturity or readiness framework, and it covers those 7 domains, from leadership to technical skills to software and data, that you need to have in place for these type of projects to be successful. And who else needs to be part of the project? You have mentioned that even though you have an analytical background, you have to work together with clinicians. You need a sponsor. You need someone who is able to protect the time the analysts are dedicating to these type of projects, who is providing you the software. Those type of things we have covered in those 7 domains that I'm gonna mention later. So why a system dynamics community of practice? This is not a limited type of project. It needs to bring different skills. And I know Douglas, he asked, is it interdisciplinary or is an MDT team that we need for these projects? And yeah, whatever way you call it, you need to bring different skills, and some of those skills, it's difficult to find all of them in one person. And even if you have all the skills, you may not have the time available. So you have to work together. This is not an individual modeling exercise that you do when you embed in a system dynamics project. It has to be a group model process in there. So you need more than analysts and modelers in that team. So we need operational and clinical team, colleagues in the group as well. There are similarities. I would say that, for example, the colorectal presentation earlier today. I'm sure all the other providers who deliver that service would like to have a model like that. Why are we expecting them to start from scratch instead of being able to share some of those models or being able to share some of the learning? So the problems we are facing in different parts of the NHS are not unique, but also the opportunities that each provider and each ICS has are not unique. We could share those resources. So bringing people together in a community of practice is a really good opportunity for all of us. We know that models cannot just be transferred and they are going to run perfectly somewhere else. They need to be adapted. But we can also think of, instead of buying, for example, licenses in different parts of the NHS, we could do a central pool case of licenses. So there is an economy of scale as well. So there is lots of reasons why the community of practice would be useful. I mean, I haven't mentioned, but sharing the learning and encouraging discussion and collaborative working are also aspects that we could highlight in there. So these are the 7 domains that we have identified that this tool is targeting ICSs, but you can use it for providers or even for teams who are trying to do some system level modeling, and in particular system dynamics. And you will have 7 areas that are mentioned here on this slide deck that you will have to assess yourself. So it will tell you where you are and what you need to do next to move in that journey and being able to successfully deliver these projects. So what could that community of practice look like? We have mentioned already sharing the learning. There needs to be some training. We need to skill up more people in this area, in this field, but also the models that are developed. They need to be some sort of quality assurance, someone with more expertise, being able to review them and say, you know, this is a really good product that could be shared with someone else in the NHS or other parts of the health and care sector. Peer support, mentoring, expert advice. Those are the things that we are thinking of in terms of the community of practice. And I have to mention that Stacey has been part of this project about the community of practice, because there is what you are doing already in the Midlands, but there is also this other national networks, AFA, and what we are trying to bring together in the demand and capacity team. But we also know there are system dynamics specific. There is an international society and a chapter for the UK. So in March, for example, instead of having our own system level event, what we did was we partnered with the System Dynamics Society and we sponsor analysts from the NHS to attend the conference. And I think it was a really successful experience because it also gives you a wider idea of how you could use this approach in other areas, perhaps thinking of your personal development. If you're moving somewhere else later, we wouldn't like you to leave the NHS. But it's also important to think about people's personal development, so you can see other aspects, other areas where you could use those skills. So we have those resources available, and we link up with the System Dynamics UK chapter in particular with their events. So we are putting together 4 recommendations to NHS England, and I know NHS England anyway, but NHS England is big, and there are different teams. So when we say NHS England here, we are perhaps referring to the Chief Data Officer at more higher level than what I could do, much, much higher. So in general, advocating for the profile of raising the profile of modeling and simulation approaches, and why system dynamics should be one of the approaches to be considered by ICSs. And then to help us to further develop and sustain this community of practice. We have done some research about open source software and what can be done with open source for system dynamics modeling, and that's not ready yet for the visual and the user interface part of it in particular. So we are suggesting NHS England to do that software available in the medium term. And for the longer term, develop something that could be open source. Until we get there, in the meantime, you're going to have to use software like Stella. So Edwin put a couple of comments in here.
We've just got a 2 minutes left to the
Oh
end
my
of
gosh,
the meeting,
okay.
Vanessa. So I think what we would do is, if anyone's got any feedback on those questions, could they, you know, put it in the chat or email it to the demand and capacity email that we've got in the chat there. But I just wondered if we've got any time, Rachel, for some quick questions for anyone who's presented their projects today. I know we're running very short on time, but we can always answer them via email if there's.
Yeah, so we have a couple of questions. So we are at time, and people will start to go away and have their sandwiches, so we'll finish quite soon. So instead of sharing those questions and rushing through them because people have taken the time to point them out, I'll add them to the questions which were raised in part 1, and if we can, and we'll respond, and I'll email the analyst network so everybody has the full picture instead of trying to rush some responses. So I would just like to say thank you very much to Phil and to James for sharing your models with us. Really appreciate it. I know it's quite hard when it's something in development and it's something very new to you. I started learning system dynamics a couple of years ago as well, so I know what it's like to not have that approach, to have that approach. I think you've done extremely well. I wish you all luck, and do come back and show us how it's developing, show us the impact that it's having, etc., etc. We're very interested. It's not like you're not going to go, we're going to forget about you. We're not. Yeah, thank you, Douglas, and thank you, Stacey, so much as well, and thank you, Vanessa. Really enjoyed today's session, and we're making progress. It's a journey. We're making such great progress, and I look forward to getting regular updates. And thank you, everybody, for coming. I'll just finish by saying, do register for the Health and Care Analytics Conference. We've only got a few spaces left, and we want you there. And I'm prioritising Midlands. I'm kind of biased. And we've got lots of new dates for training programs, which I'll be emailing you about. But the PHM Analyst Programme is available in 3 weeks' time. So please get yourself registered on that. Thanks, everybody. Enjoy the rest of your days, and bye-bye.
Thank you.
Bye-bye.
Thank you,
Thanks,
Rachel. Thanks very
everyone.
much.